And Dr. Gensler, and I'm really excited to introduce Dr. Lianne Gensler. She's a rheumatologist and a professor of medicine at UCSF. She serves as both the program director as well as director of the UCSF ankylosing spondylitis clinic. And I've been sort of following her career, not stalking her, but she has really done a lot in the world of axial spondyloarthropathy and also really rose up through the ranks of academic medicine. But more importantly, she also has had work-life balance that I've always cherished, and she's raising 3 children, and we all know how that work-life balance matters, and she has really perfected that. So I'm really excited to hear. We're both going to attack the issue of whether or not TNF is still the standard of care, and I'm going to welcome Dr. Gensler to talk about axial SpA.
Thank you, Dr. Husni. I'm excited to be here, and this is going to be a great session. It's a great topic. I will not address well-being, my own well-being today. I did not get to the gym this morning before the start of this session, though I thought about it. Okay, so today we're going to talk about axial spondyloarthritis and whether TNF inhibitors are still the standard of care. And I'm going to use a case-based approach to sort of address when it is and when it isn't, at least in my experience. And I'll bring in the guidelines that exist, both the American College of Rheumatology guidelines and then the new ASAS-EULAR guidelines that were recently published this year. So these are my disclosures. I will talk a little bit about off-label use of therapies. So let's start with a case. And this is a patient that I saw, now it's a couple of years ago. At the time, she was 21. 2 years of subacute onset intermittent buttock and low back pain with certain movements, no morning stiffness. She did have nocturnal back pain, no history of what we define in axial spondyloarthritis as extra musculoskeletal manifestations. Everyone has their own terminology they use, but no uveitis, inflammatory bowel disease, or psoriasis. And she did have a past medical history of irritable bowel syndrome, not uncommon. She'd had a colonoscopy at 18 that was negative. And she had no family history that was significant. And then her exam, really no tender swollen joints, no dactylitis. She had tenderness over L5S1 and the right graded trochanter. And you'll see I define this as enthesial tenderness. I try not to use the word enthesitis because enthesitis is sort of an objective entity that is hard to determine just by whether someone has tenderness to palpation at that area. And then her modified Schober was 3 centimeters, an increase from 10 to 13, which technically by normal reference ranges is actually normal. Her labs, she was HLA-B27 positive, and she had a sedimentation rate of 15 and a CRP of 4.1, which by our reference range is actually normal. One could argue whether that's a little bit high for a 21-year-old. So this is the MRI, and we're really here to talk about treatment today, so I'm not going to focus on diagnosis, but just to remind you, I think we should all be looking at our own imaging studies. And so on the right side is the fluid-sensitive sequence, that's the STIR sequence, and you can see the bright bone marrow edema surrounding both sacroiliac joints, telling you that there's inflammation. And then on the left side, this is the T1 fat-sensitive sequence. You can see the fat. Do I have a... You can see obviously the fat over here, and then you can see where it's bright over here on STIR, it's dark on the corresponding T1. So this is a good example of clear active bilateral sacroiliitis. Sacroiliac joints are normal, so she has axial spondyloarthritis. This is her. I like disease activity measures. I like them both at status, and I like to follow them over time. I think it's really helpful for patients to see where they are. 21-year-old with a BASDI, Bath Ankylosing Spondylitis Disease Activity Index of 6.4 is quite high. And then her functional impairment also quite high for a 21-year-old. So you can see this is a really affected patient. Taking into account her inflammatory markers, the most robust measure we have for disease activity is the ASDAS-CRP, giving her a 3.4, which is high disease activity. So talking about treatment, what do we do for her? And back to that first question, is TNF the standard of care? And this is where my first response is going to be not always, because actually first-line therapy in a patient with active disease are NSAIDs. And I don't think we should be forgetting about NSAIDs as a really good option for many patients with axial spondyloarthritis. I would say about 30% of my patients are on NSAIDs alone. Not everyone needs to be on a biologic or a targeted synthetic agent. And so I do use NSAIDs first line in active patients continuously. There's not a preferred NSAID. I tend to, though this isn't based on evidence, but I tend to like things, especially in young patients, that are once a day. I think it's hard to take something more than once a day if you've never taken any medications in your life. And so I tend to do daily dosing. It also tends to have longer half-life. And then physical therapy, of course, not forgetting about the non-pharmacologic things that are strongly recommended based on the evidence. And you know this legend, which we use in all ACR guidelines, but dark green being strongly recommended. Obviously, against systemic glucocorticoids, moderate doses do not work for axial disease and, of course, compound the risk of bone loss in these patients. All right. So this is the new 2023 ISSU guidelines. And why I'm bringing these in is the ACR guidelines are 2019. They're just about to go into another revision, but we won't have them for another 2 years. So these just published in January show us still that NSAIDs are first line in patients with active axial spondyloarthritis. Because there's a lot of well-being at this meeting, I also want to highlight the point about regular exercise, education, smoking cessation. Also, by expert opinion, we recommend that people consider these non-pharmacologic approaches to managing their disease too. All right, so let's continue on the case. And so remember, she had a lot of gastrointestinal symptoms with this IBS diagnosis. And so the question is, would you use an NSAID in this patient who has a lot of GI symptoms to begin with? And so I thought about this a lot, and I thought, well, maybe I would send a fecal calprotectin. Does anyone, just show of hands, use a fecal calprotectin in patients? So, yes, some of you. I really like the fecal calprotectin. I think it's got limitations. It's like a sed rate of the stool, so it's looking for inflammation in the colon mostly. It can be falsely elevated if you're an NSAID user, so you have to think about that if you're starting an NSAID in someone. And it's supposed to be done as a first morning, but it's exquisitely sensitive in colitis. It's not specific. You could have a colonic infection and it would be elevated too. If you have ulcerative colitis and there's activity, it's a great test to send, though, because it does pick up on disease activity. So I decided I would send a fecal calprotectin. And I started meloxicam, that's my daily NSAID that I spoke about. And I told her to watch for gastrointestinal symptoms. And if her fecal cal was going to be elevated, then she would need a colonoscopy. And that's my usual approach to thinking about these patients. And then also referring her to physical therapy, standard of care for non-pharmacologic approaches. My chart. So this is our patient portal where patients message you. I'm sure you all have the same experience. And so I messaged her with the fact that a fecal calprotectin wasn't completely abnormal, but it was in that indeterminate range. And the recommendation is to repeat it. And I was asking her how she was doing on the meloxicam. And she feels much better, great, except look at all these symptoms she has now. She's having diarrhea, constipation, stomachache. This is like your worst nightmare to get at night. Canker sores, is this expected with meloxicam? And I'm thinking, oh no, okay. So she's going for colonoscopy and she has mild ulcerative colitis now. So in conjunction, multidisciplinary care is the way we operate, right? So I work very closely with our gastroenterologist and we discussed that it would be safe to consider switching her to celecoxib, being cox-selective. And that's based on some good data actually done by gastroenterologists. This is an ulcerative colitis where they did colonoscopy before and after, randomized them to high-dose celecoxib versus placebo, and there was no increase in flare in patients with known ulcerative colitis. And so we put her on celecoxib, and she was doing well until 4 months later. She presented with worsening gastrointestinal symptoms, admitted with severe ulcerative pancolitis, started on Solumedrol in the hospital and infliximab. And of course, I'm thinking to myself, what have I done? And so this is where now TNF inhibitors become standard of care. In a patient that has IBD and active axial spondyloarthritis, we're not going to use an NSAID anymore. We're going to use a TNF inhibitor and preferably a monoclonal antibody-based TNF inhibitor in the setting of axial spondyloarthritis and IBD. Also noting, though I'm not going to present a case, but if you've had recurrent anterior uveitis, we would also similarly recommend a monoclonal antibody-based TNF inhibitor. And so this is a good example of where TNF inhibitors really do work across the spectrum and should be considered. Often first line, especially in someone that has these other extramusculoskeletal manifestations and you're thinking from the beginning, I cannot use an NSAID because of contraindications. These are the guidelines from Asis Ular, and similarly, you can see that in this patient, you would start a TNF inhibitor, and especially in the setting of inflammatory bowel disease. Now, the one difference here to the ACR guidelines is you see a very lateral box that includes TNF inhibitors and IL-17 inhibitors. JAK inhibitors, there's a little asterisk. It's not if you are a patient with an older patient with cardiovascular risk factors. But really, you're seeing that IL-17 inhibitors and TNF inhibitors are sitting more lateral to each other here, whereas in the ACR guidelines, IL-17 inhibitors came after TNF inhibitors, and that's because at the time that they came out, we had actually very little evidence for their efficacy beyond the initial phase 3 trials. The one caveat here that is important to point out is that in the presence of significant psoriasis burden, we should be thinking about IL-17 inhibitors even over TNF inhibitors because we know that they are more efficacious for the skin than TNF inhibitors are, and that depends on the skin burden. TNF inhibitors work well for skin. IL-17 inhibitors in head-to-head studies just work better. Okay. This is looking at patients, again, Asis Ular. And here, I think that I just want to highlight this difference from the ACR guidelines is that in patients with non-radiographic axial spondyloarthritis, so they don't have a radiographic burden of sacroiliitis on X-ray, but they have the diagnosis, and usually these patients are going to have some MRI findings. The recommendation is to require that they have either an MRI with positive sacroiliitis by bone marrow edema or an elevated C-reactive protein. We don't require that in the US. We sort of gold standard, the rheumatologist's diagnosis of active disease is enough. And one could argue, I think, that there is merit in both places. And the point here is that if you don't have an objective sign of inflammation anywhere, if you don't have bone marrow edema anywhere, if you don't have an elevated CRP, your chances of responding to a biologic are much lower. I'm not kidding, this is the same case. 6 weeks later, after starting the infliximab, she developed severe pustular psoriasis, this poor 21-year-old, right, who had nothing except IBS coming into this. Well, it was IBD, probably. But severe pustular psoriasis, and so the question is now, what do we do? And so this is my table of drug classes across the spectrum of diseases and what works for what. And so we know she has axial spondyloarthritis and ulcerative colitis. And what you can see is that there aren't a lot of green bars that line up across the spectrum. So we know TNF inhibitors, as a standard of care, will work across the spectrum, and that is really helpful. And I think that we started in such a good place we had NSAIDs, and then we had TNF inhibitors. And so we started out the gate being able to treat the whole spectrum. And then we've developed more targeted treatments, and they haven't worked across the spectrum. So you can see IL-17 inhibitors don't work in IBD. IL-23 inhibitors don't work in axial spondyloarthritis. Vedolizumab gut selective, doesn't work in anything else. And then coming down here, JAK inhibitors is the one class of drugs that, again, works across the spectrum. I added, for this talk, because it's relatively new, is deucravacitinib, which is a TYK2 inhibitor, or JAK4. And I think what's interesting here is that it's showing efficacy, so it works in psoriasis, has early efficacy data in psoriatic arthritis, but data in ulcerative colitis is negative. So again, even though it's a type of JAK inhibitor, it actually does not work based on the phase 3 data in ulcerative colitis. And I think that's going to impact the way we treat our patients who have both of these manifestations. And then there is just off-label use of combining drugs. Happy to talk about that maybe afterwards, but there are patients that have active disease, IBD typically, and arthritis, and I'm needing to combine drugs to really control both. So this is the data for JAK inhibitors, and just noting on the left is the tofacitinib data, and the right is the upadacitinib data. There's only a radiographic trial in tofacitinib, and see there that the endpoint is an ASIS 20, which is about a 20% improvement. On the right, the endpoint is a ASIS 40, a 40% improvement in radiographic disease and non-radiographic disease, both meeting their primary and key secondary endpoints. And these drugs, upadacitinib, has an indication both in radiographic and non-radiographic disease, tofacitinib just in radiographic disease. And then, from a safety standpoint, these are short-term studies, but we're not seeing MACE or VTE in any of these patients. Keep in mind that the clinical trial patients for axial spondyloarthritis are younger than the RA patients or psoriatic arthritis patients. What we do see is zoster across the spectrum. That's a class effect, and similarly a risk in patients with axial spondyloarthritis. So recently I saw her actually, and she was in drug-induced remission, ASDAS less than 1.3, no gastrointestinal symptoms, no psoriasis, and she's on the high-dose tofacitinib because that's what's approved for ulcerative colitis. And I'm thinking, what does this mean for her risk of VTE? IBD patients are a little bit more hypercoagulable. She tells me she wants to do birth control, and she's thinking about a vaginal ring, which of course made me shudder just a little bit. And so the question is how to counsel these patients with regards to VTE risk when they're on the high doses of particularly what we know from tofacitinib based on the oral surveillance data. And is this generalizable from a safety standpoint to our patients with spondyloarthritis? So the take-home points from the first case, NSAID's still a standard of care for first-line therapy unless they have IBD, and then TNF inhibitors will become standard of care as first-line treatment. And in the presence of TNF inhibitor adverse events or contraindications, certainly other mechanisms of action are preferred. This is the second case. This is actually this patient, and at this time is now probably 6 or 7 years ago. So it's a while ago, but the case is still relevant. At the time she was 28, she has axial psoriatic arthritis. And what I mean by that is she actually meets modified New York criteria. She has radiographic axial spondyloarthritis, and she meets Caspar criteria. You can see she's got peripheral joint involvement in addition to sacroiliitis. She at this point had failed or was intolerant to multiple conventional synthetic DMARDs and TNF inhibitors and was on her 4th TNF inhibitor here looking like this. She had poorly controlled psoriasis, and her course kept being complicated by the fact she would get skin infections, would need to hold her biologics, then would flare her arthritis, and her skin would become worse. And this was a good day. This was a bad day. And I remember we had just had our first approval for IL-17 inhibitors, and I thought to myself, all right, 4 TNF inhibitors, the skin burden's not going anywhere, it's time to think about another mechanism of action. So this is really thinking about the patient who has active, and these are the 2019 guidelines, active axial spondyloarthritis on a TNF inhibitor. What I wouldn't do is add methotrexate to this patient. It's not going to make a significant dent in her burden of skin disease, and it doesn't do anything for her axial disease. And we don't do co-DMARD therapy in these patients because it does not add to the efficacy of the axial disease. And then, so these are the old no, they're not old. These are the current ACR guidelines. But I think the point here is that, this was at a time where we had just had IL-17 inhibitors approved. In fact, when we developed these, ixekizumab didn't even have FDA approval. But you can see that it's coming down third-line therapy after TNF inhibitors, and then is stratified by whether you're a primary non-responder or a secondary non-responder. And having very little therapies in our toolbox, the thought is, well, if you were a secondary non-responder, in other words, you had a response to a TNF inhibitor, but you lost that response, then there was observational data that you would respond to a second TNF inhibitor. And that's where this comes from. Versus you never responded, probably your chances of responding to another drug in the same class are low. In fact, it's around 11%. So we would have you switch to an IL-17 inhibitor. So it makes sense at the time that we had these. And this is the current guidelines, just going back to that point, that actually now they're very lateral to each other, and you might start with an IL-17 inhibitor earlier on in a patient like this with high skin disease burden. These are just to remind us of the ways we can inhibit IL-17, and so these are the 2 drugs that are approved for axial spondyloarthritis, and then we shall talk a little bit about bimekizumab, which is a new molecule that inhibits both IL-17A but also F. And then what we don't really use in arthritis is brodalumab, the receptor inhibitor, but it's approved for psoriasis, and so you will still see it being used in patients that have it as an extra musculoskeletal manifestation. This was the patient a month later, a month after starting an IL-17 inhibitor. So quite a remarkable improvement after I had not been able to control it at all with any other mechanism prior. Very briefly, a third case on one slide. And because I wanted to make sure that I wasn't presenting you with a case that I had started an IL-17 inhibitor from the beginning, as I just showed you a case of someone that had failed a TNF inhibitor. And so this was a patient that I did start on an IL-17 inhibitor from the beginning. She was a 33-year-old at the time with 2 years of neck pain and stiffness. It's a complicated way of describing the symptoms, but inflammatory symptoms, exercise and NSAIDs help, but not completely. No peripheral joint pain or swelling. And then she had this rash on her hand, which had been diagnosed with palmar-pustular psoriasis. No other manifestations. She had a medical history of cervical dysplasia, B27 negative, high inflammatory markers, and you can see, so her sacroiliac joint, she has bilateral radiographic sacroiliitis with sclerosis, joint space narrowing, a little bit hard to see here. I think it's also, what I like about the AP pelvis is you can see the fluffy new bone all the way around her pelvis and greater trochanter, so that's sort of in keeping with what we'll see even outside of the joint, the periarticular new bone. And then take a look at her neck here, and you can see her facet joints are completely ankylosed, and she has a couple of marginal syndesmophytes. So why did I pick an IL-17 inhibitor at the time as first line for her? She had already tried NSAIDs at the time and did not fully respond to them. She clearly had damage and was at high risk for progression, right? Damage is the biggest risk factor for more damage in the spine. And at the time, and again, this is several years ago now, but I was a little bit nervous about the cervical dysplasia and what TNF inhibitors would do to that. And there had been some evidence in rheumatoid arthritis, and so I decided, based on the high burden of IL-17 in palmar-pustular psoriasis, her significant damage at baseline, and then the cervical dysplasia, to use an IL-17 inhibitor in her. These are the data for axial spondyloarthritis of all the IL-17 inhibitors, starting with the oldest ones on the left. So you can see secukinumab, there are 3 trials. The measure trials were done in radiographic axial spondyloarthritis using an ASIS-20, and then the non-radiographics trial with secukinumab using an ASIS-40. And then and the one thing about the secukinumab trials is that they included up to 30% of patients that were TNF inhibitor experienced, as opposed to the ixekizumab trials, which actually separated their trials into patients that were bio-naive and patients that were bio-experienced. You can see lower response in the bio-experienced group, and then the non-radiographic study. Now, bimekizumab is the latest MOA to be studied in the category, and I think what's great about these 2 studies, which were published as one study in Annals earlier last month. So radiographic on the left, non-radiographic on the right. A small portion of each one included people that were TNF inhibitor experienced, but what you see is very similar responses across both radiographic and non-radiographic, very similar placebo responses. And in fact, when you look at TNF inhibitor experienced patients, their responses numerically are the same as the bio-naive patients. So whether that means those numbers are small, but I think what we're seeing here is good efficacy across the spectrum. I don't know if Dr. Husni is going to talk about this, but just in terms of mechanisms of bimekizumab head-to-head, you may have seen this in New England Journal of Study. I don't know how this will play out with arthritis, but you can see that for skin clearance, bimekizumab does better than secukinumab does at the high dose, so this is 300, but the bimekizumab also has a significantly higher burden of oral candidiasis. This is double the dose that we use in arthritis, so it's a 160 dose in arthritis, so we don't see these kinds of candidal infections. None of them are severe. They're all mild to moderate and typically oral. Just this issue of whether IL-17 inhibitors increase the risk of IBD, I think that comes up a lot. I personally have seen it in my own patients, but if you look at the literature, actually it's negative, all of the studies that have been done. So this is the most recent meta-analysis, SLR and meta-analysis showing no increased risk, and that takes into account the baseline risk in the population of IBD. And then using the French National Healthcare System, they actually looked at patients with psoriatic arthritis, AS, and psoriasis, and compared IL-17 inhibitors to etanercept and did not see an increased risk of IBD there. So I do think there is a possible relationship. There is biologically, there is from IBD trials, And I think the question is just to really screen your patients for gastrointestinal symptoms, consider the fecal cal, remembering it's only good for colonic inflammation, and then really consider it if your patient also has hidradenitis suppurativa. I think there's a big overlap there with IBD. I'm going to end with, good, 1 minute. I'm going to end with the SURPASS trial. So this is the first head-to-head trial in axial spondyloarthritis. This is radiographic axial spondyloarthritis comparing two MOAs. And there's a lesson on both sides of this I think we can take away from it. This is a late-breaking abstract at ACR Convergence. So this was a study funded by Novartis to compare secukinumab at two different doses at 150 and 300 compared to an adalimumab biosimilar for the primary endpoint of radiographic progression. And so this population was actually enriched. I love enriched populations in clinical trials. I think we can get to these answers in a more nuanced way, thinking like oral surveillance. So this population had to have radiographic disease. They had to have either a high C-reactive protein or syndesmophytes on their X-ray. And then they were followed for 2 years, randomized to one of these three arms. And what you can see at the top is the cumulative probability plot, and there is no difference across any of the MOAs. There is no difference in radiographic progression. And then more encouraging is actually just a very low rate of progression amongst these people. You can see no progression in 66, 67% of patients, regardless of the arm, over a 2-year period. And that is unusual for this population group that is really enriched to progress. We would have expected a higher rate of progression. So I think this was a negative trial, but I think what it tells us is that the drugs look very similar for radiographic progression, and what I'm not showing you is the clinical endpoints, but they were similar too, and the safety endpoints were similar too across all of these arms. So I think despite the negative trial, it tells us that perhaps we have good options here that may be more equivalent than we initially came out with because we had just TNF inhibitors for so long. So the take-home points from this is IL-17 inhibitors are the preferred MOA in the presence of important psoriasis burden. I think we would say that in psoriatic arthritis, but also in axial spondyloarthritis. And I start important because I think as rheumatologists, we often, we have a sense of what is a high burden of skin disease, but sometimes we forget to ask the patient, and patients are very bothered, sometimes more bothered by their skin than they are their joints or than we may perceive. So remember to take that into account. And then the similar radiographic progression in radiographic axial spondyloarthritis, whether an IL-17 inhibitor or a TNF inhibitor, really similar clinical endpoints too, and safety, suggesting these MOAs are more lateral. And I will end there and look forward to questions. I assume that we'll do it at the end, Elaine? Yeah, perfect. Thank you.
Thank you, Lianne. We're going to switch gears to psoriatic arthritis. All right. So this is one of the first patients that I saw in my derm room clinic that I ran first in Boston and now at the Cleveland Clinic. This is really what got me interested in this field of psoriatic diseases. So I'm going to just to tell everyone what we're doing, in addition to talking about TNF and treatment, I want to really emphasize the heterogeneity of this disease and really recognize that even as I'm making these slides, I have to make new ones because there's like new studies, new drugs that are being approved for psoriatic arthritis, and then to discuss some of the treatment strategies. So as everyone in this room knows, that it's more than just the skin and the joints that are affected. It can affect eyes, uveitis, enthesitis. It can have changes both in the skin and the nails. So it can present in any different way, which makes it quite challenging. So this is sort of the prototypical sort of cytokine, adaptive and innate immunity slide that we show that as we're getting to better understand the pathways involved in both axial SpA and psoriatic arthritis, we realize that we are entering into a new era where we can't just borrow from rheumatoid arthritis, which is what this field has been doing for a long, long time. And now we have many new targets that we can see. And particularly, I want to just highlight in that big cartoon, it's as Len Calabrese said this morning, it's really about a balance, right? So depending on which lab is looking at which cytokine becomes the top cytokine in that chart. But for spondyloarthropathies, the role of the IL-23, IL-17 pathway has become really important. So what we do know is that there is an enriched population of dendritic and macrophages that produce IL-23. And so this is where the excitement came in to try to block this, but there is in really specialized cells in the enthesitis in different areas, we see an increased amount of IL-23. Whether or not we know exactly what triggers that, which is what those little highlight notes on the top, whether it could be a genetic HLA-B27 factor, whether there could be stress, mechanical stress, whether it's a microbiome. So all the talks that you heard about this morning could be contributing to what triggers that. And what's really interesting in this particular disease is that not only do you have the bony erosions that we know of, but we also have bony formation. And how can that be, right, in the same disease process? And so what we see when we look at these immune pathways is that IL-23 can activate resident T cells as well as naive T cells. And you can see downstream the different cytokines that gets proliferated and stimulated that then becomes important in the phenotypes that we see, the inflammatory burden, the bony erosions, and the bony formation. So here's the list of approved treatments that are both for psoriatic arthritis and axial spondyloarthropathy. The ones in green, as you can see, are approved for both. And then in psoriatic arthritis, we also have some additional treatments that I will also go over, which really makes this question of whether or not TNF should be the standard of care becomes more important because we have a lot more to choose from. So this is a slide that really highlights all the different pathways that have drugs that are approved, not just for psoriatic arthritis, but also used in many of the other diseases that we take care of. And so it does become really challenging about which one we should choose and why we should choose certain ones over the others. So this is a slide that I used to teach a lot of the trainees and how I really think about psoriatic arthritis. So in many of the diseases that we treat, we really look at joints and disease burden. But here, I feel that there are patients that come in with mild disease, mild psoriasis, mild joints, and we can treat them, without a biologic. And then I see people that are really severe on the gray box, severe joints, severe psoriasis, and we really then push the envelope and we're trying many different biologics because they're very recalcitrant or refractory. But it's the other boxes that I think where we are probably not as good as trying to treat because this needs a lot of interdisciplinary care. And this is where I started better understanding the benefits of really not just reading someone's note in dermatology or GI, but actually picking up the phone and talking to them. And I realized that sometimes what is on the notes could sometimes be a little different in how you're treating the patients. So these other boxes where they have mild psoriasis and severe joints, or the other way around, severe psoriasis and mild joints, I think is where we can make the biggest change as we're moving forward with all these different disease treatments. So how I think about these overarching principles, how I think about what we should do in these patients is I look at their disease burden, I look at the concept of treat to target, which a lot of us know from the RA world, and then the guidelines, just as Lianne has went over all of the different guidelines and how to use them in our patients. So in psoriatic arthritis, we have similar concepts. So I wanted to spend a little time just kind of having you think about disease burden, right? Because as rheumatologists, we're really used to doing joints and joint counts and understanding that. But really, in psoriatic disease care, the skin burden does become an issue, and it's not something that we may always feel comfortable with. So as you can see here, there are measurements that we use for clinical trials and measurements that we use for clinical practice. And it's not always something that we regularly do in our clinics because a PASI score, for example, is really hard to do. And it could take up your whole 10 minutes that you had with your patients. So there are other practical clinical guidelines that we use, such as body surface area and so forth. But this slide is just to remind us that even skin burden is not that easily sort of measurable, and there's different ways that they do that. And then this slide, which focuses more on rheumatology, which I don't have to say in this audience, we also don't agree on the exact measure that we should be using, whether we should be using some of the clinical trial measures, the clinical practice measures, and what do people do in their office on a daily basis. So all these are also going to play a role in how we're going to pick which treatment that we want. I will tell you that in psoriatic arthritis, we have borrowed this ACR 20, 50, 70 from the RA world, but we are now realizing that ACR 50 is probably becoming more of an acceptable target for what we're looking at in psoriatic diseases. Unfortunately, there are still limitations, as we know, because the ACR doesn't really reflect all the clinical features that you see in psoriatic arthritis, but it is what many of the drug trials are using. We also have something called TICOPA, which I won't go into detail, but just to remind us that a similar treat to target, we are looking at groups of psoriatic arthritis patients that go through tight control. They're seen every 12 weeks with treatment changes versus in the blue bar, standard of care. They come when they want. There is no proscriptive changes in their treatment. And what we found is that patients that are under tight control do have greater improvements in their signs and symptoms of psoriatic disease, therefore supporting the role of treat to target in psoriatic arthritis. And then lastly, practice guidelines, which I won't go in such detail. We do have many different ones that are available in psoriatic arthritis. Currently, the ACR NPF guidelines do rate TNF as the standard of care. That is the first line treatment for someone with severe active psoriatic arthritis. We also have EULAR guidelines, as you can see here, and we also have GRAPPA, which is an international group that also has guidelines that were recently updated. But our guidelines are not as simple as I can just show up a chart and you can just kind of go down in sort of a recipe kind of cookbook way. They have really different concepts. So the ACR MPF guidelines are really looking at treatment A versus treatment B. And the GRAPPA guidelines are really looking at a domain-driven approach. So what I mean by that is we have many different domains in psoriatic arthritis, whether it's the skin that's more active, the joints, whether it's enthesitis, whether it's dactylitis. And based on those domains, they have an algorithm for treatment. So I don't have time to go over each of these, but just to know that there are practice guidelines that are out there and that these are getting developed from time to time as well. So going back to TNF, since this is what we're trying to answer the question of whether or not this is the standard of care, I'm going to show you all the TNFs that are available in psoriatic arthritis. And the first bar is going to look at ACR criteria. So this is joints. So as you can tell, even the highest bar, the green bar that you could see, is probably in the 40 to 50% range. So that means there's another 40 to 50% that are not responding, that we still need to try to treat. And then when you add the layer of PASI, which is the skin burden, you can see that many times the skin is doing much better, meaning TNFs are able to have a much better response, sometimes up to PASI 90, which is 90% clearance of their disease. So it looks like the dermatologists are a little bit ahead of us in terms of treatment than we are, meaning we only have 40 to 50% that we can make a difference in, while in dermatology, they are doing a little bit better. So the next question is, what do people think about methotrexate? So how do we think about methotrexate in psoriatic arthritis? It is really well known in many trials in RA that methotrexate really helps the biologic DMARDs. But in psoriatic arthritis, it's not as clear. So many times we do it. Many times we tell them we can take off the methotrexate, but how do we know whether or not this really helps somebody? So there's been many different papers weighing the use of methotrexate. One of the bigger articles that got a lot of splash was called the MIPA trial, and in that trial, it showed that methotrexate was not as helpful in psoriatic arthritis. But none of these trials were as specific as the SEAM trial, which I'll take a little time to go over. So this is a trial that was done prospectively. So patients were randomized to methotrexate alone, etanercept alone, or the combination of methotrexate and etanercept. And I think what many people were thinking was that the combination's got to be better because that's what we're used to. And we're quite surprised that based on not observational studies, right, not looking back, but actually randomizing them in a prospective study looking forward, that the combination of etanercept and methotrexate actually did not really make a big difference in helping the burden of the disease. And so that kind of made people Not sure we should really, use as much methotrexate, but I will say in practice that I probably still do have patients that are responding to both over one. But I think this trial has helped me maybe, backed off a little bit, especially if patients had a lot of problems with methotrexate, as we all know, and even if they don't do well on subcutaneous methotrexate, that perhaps it might be time to go on to different mechanism of action if they're not getting the response that you want. So just to recap, 40% of patients are not responding in the first 6 months. What do people know about switching between classes? So if I don't do well on one TNF, should I switch to the next one? Should I switch to the third one? Because they're getting some response. And there are some registry trials that show that it's sort of a losing battle. So as you switch more than one or two, it's probably not really recommended to switch to 4 and 5 for you to complete the cycle of all the TNFs. There's also some concern about real world data showing some diminished drug persistence with each successive TNF. So we're not really highlighting that you should be, cycling through all the TNFs at this time. So I'm going to spend the next couple slides going over, well, if TNF is not the standard of care, what do we know about all the different treatments that are out there? So I'm just going to do a kind of a quick review of all the things that are available in psoriatic arthritis, so you can think about these drugs such as ustekinumab. This was the next one out. That was for PsA after the TNFs, and it probably wasn't really meant to block both IL-12 and 23, probably meant to block 23, but because they have a P40 subunit, it was able to block both. And you might say, wow, what if we block both? It's probably better than blocking one. So what did the trials show? So here I can show you that using a primary endpoint of ACR20, didn't really do much better than what we see with TNF, maybe even slightly a little bit worse, but it was like 49, 27, and 14 for ACR 20, 50, and 70. Now, on the skin side, dermatologists really like this because there was really a good safety profile. It was every 12 weeks. It was really great. They didn't really have to do this all the time, and it had pretty good skin response. But unfortunately, on the joint side, we were not so thrilled, and so rheumatologists did not really pick up on the use of this as much as maybe some of the dermatologists. Abatacept for psoriatic arthritis also showed some nice efficacy, ACR 20, 50, 70, as you can see here for response. We would even see some response in people that failed TNF before. So we have experience with this in RA, but unfortunately on the skin side, which I didn't show you, probably not as robust a response as we're used to with some of the newer agents. So still nothing that was sort of winning over TNF inhibitors. So then the next thing that came along is IL-17, which, as Lianne has said, this has really changed the way that we're looking at these spondyloarthropathies. We know that there have been some really great efficacy that we see both in joints that are very similar to TNF in terms of secukinumab and izokizumab. So secukinumab data I'm showing you here against other TNF inhibitors, but I do have to have a caveat, these are not, really not should be used to compare, but just to kind of have a gestalt looking at the ACR 20 responses that IL-17 is doing really good compared to, not better, but doing just as well in TNF. The sort of little bit of a downside for this is in the skin, in that IL-17 probably works better in the skin than TNF. So if you have somebody, so joint-wise they're comparable, but skin-wise, the dermatologists are probably a lot more excited than we are about IL-17. This is the ixekizumab, which you see similar, nice, good responses to the joints, but same with skin disease. They're doing a lot better than they are with joints. So this has really been a new player on the block because it has comparable efficacy and then maybe even a little bit better skin efficacy compared to TNF. But in our patients, most of the ones that we see probably respond to both the TNF and the IL-17 because we're not seeing people with really big skin burden. So the next is the IL-23 inhibitors, which the dermatologists really pounced on this, right away because these drugs have probably the best skin response that they've seen in all the classes, so they were really excited. So the question is, how are they doing with the joint responses? So guselkumab was the first one that was approved, and here you see that they have pretty comparable joint responses to a TNF inhibitor. Maybe not better, but sometimes a little bit worse, but it still has some efficacy. But it wasn't like a big win, you know, a big home run here but in the skin wise, it was a really a good home run, and there's really also a good safety profile. So I would say you are probably starting to notice that a lot of your derm colleagues are using a lot of the IL-23s at this point, because for what they're looking at and their skin burden, they're doing really well. Risankizumab is the next one that was approved in the Keepsake 1 and 2 trial, again showing some good responses in ACR 20, 50, and 70. I'm not sure I can say that they're better than what we're seeing in TNF, but we're seeing some good response. And once again, though, in the skin disease, which I didn't show you, skin is just having a really great time. They're getting PASI 100s where they're just clearing patients on these IL-23 inhibitors. Tildrakizumab, I only have some early data. This is not yet quite approved, but also showing a good response to ACR 20, 50, and 70, very similar to its counterpart in the other IL-23 inhibitors. We're probably more to come as we're getting more data on this IL-23. And then our biggest surprise is that as these drugs are getting approved for psoriatic arthritis, so the TNFs, the IL-17s, we were thinking that this would also be good in axial SpA. And to our big surprise, the IL-23 inhibitors, these trials were stopped and are not used in axial SpA. And so I just showed you a cartoon when I started off showing all these cytokines that were involved in these pathways and all these similar redundant pathways that we see in axial SpA and psoriatic arthritis. Yet one of the big surprises is that that the IL-23 inhibitors do not work and are not an option for axial SpA, but still an option in psoriatic arthritis. So we're going to go on to tofacitinib for psoriatic arthritis, which, as we all know, in RA, there is some reservation in patients with cardiovascular disease. But as a whole, it does have some response in psoriatic arthritis as well and approved. And so is upadacitinib, which has also been approved for psoriatic arthritis. So we have all these other options, oral options here, JAK inhibitor, that we can be using for psoriatic arthritis as well. So I'm just going to stop here because I just went through, I know, a lot of different treatment options, but I thought it's important just to kind of remind us of what is being approved for psoriatic arthritis. So I had this 38-year-old school teacher who's had longstanding psoriasis since her 20s. And she had only been treated with topicals and light therapy, and she was, pretty happy with her care at the time. Unfortunately, she started developing some more musculoskeletal symptoms, some Achilles tendonitis that wouldn't go away. She had some wrist swelling, and she was diagnosed with psoriatic arthritis, and she was started on methotrexate. She did actually pretty well on methotrexate for several years. Then she got married and she wanted to have children. She was then taken off methotrexate. She actually did okay off of methotrexate, and she did not actually restart any medications even throughout having her second child. But then, unfortunately, that honeymoon didn't last, and she then developed both pretty severe skin and joint flaring when she came back to see me. And she's been doing a lot of reading, and so she started asking about, she didn't really want to go back on to methotrexate, although she was done having kids, and she did try for a little bit, but she didn't have a good response, and she kept flaring. And so the next question was, would you start a TNF inhibitor? So just by a show of hands, just after giving you all that whirlwind of all the different treatment options, how many would start a TNF on this patient? So she's 38-year-old. With both skin and joints flaring. Okay, she's never seen a biologic before. IL-17? Okay, I should tell you that she had a greater than 10% skin burden. Not sure if that would change any of your answers. IL-23? No one would start an IL-23. Wow, okay. JAK inhibitor? Maybe? Okay, so This probably parallels what we see in practice. Rheumatologists are really used to what they're used to, and TNF and IL-17 are probably where I see most hands being raised. But I ask this question a lot, and it's getting a little harder because as we're getting more data, we're realizing that many of these do have pretty good efficacy with joints. But I think what separates them is when you have a really high skin burden, where these, I think, decisions become a little bit trickier. So here is just a slide looking across all the different treatments in terms of different classes, a TNF inhibitor, IL-12/23, IL-23 or IL-17. And what I wanted to show is that that there are some differences in terms of skin and PASI 90 scores that you see that you can see the IL-23 is really having a much more robust response with skin. And so sometimes you have to keep that in mind. Now, these are all individual studies, so these are not head-to-head comparisons. But for the case that I just showed you, do we have any more data that we can share with you to kind of make that decision? And so the long-awaited head-to-head trials we've been asking for are finally published. And so the two that are looking at IL-17 versus adalimumab, it's the EXCEED trial and the SPIRIT head-to-head trial as well. So what have we learned from these head-to-head? Because we've been long awaiting this so that we can answer the question of whether or not TNF is standard of care. So I'll go over the EXCEED trial first. That's secukinumab versus adalimumab. That's a year-long study that they did. It was a completely blinded study. They used their primary outcome was an ACR20. And in this particular head-to-head trial, it did not show a difference between IL-17 and TNF inhibitor. So now let's look at the SPIRIT trial. So same head-to-head, but it's with ixekizumab and adalimumab. They were not completely, there are some nuances. They were not completely blinded. The patients knew what they were getting, but the assessor was blinded. They used a different endpoint. They didn't just use a joint endpoint. They used has not really been validated before, but they used a co-primary endpoint, so an ACR 50 with a PASI 100 score as their endpoint. And in this particular trial, there was a improvement in the ixekizumab over adalimumab. But like I said, there are nuances to these studies, and so there are differences that we see that may be driven by the skin. So even though we do have head-to-head, and because of sort of the some differences in the way that the trials are done, may not be able to conclude for what we want exactly to know. There are going to be a lot more head-to-head trials, I'm sure. It's really interesting that in the dermatology world, which I'm not showing you now, they have a lot more head-to-head. I mean, they have head-to-head at almost the same time that the drugs are coming out, and and so we have a lot more data on the skin side than we do on the joint side. Lianne talked a little bit about bimekizumab. There's been a lot of interesting data if you're following during the meetings that this may be one where both joint and skin have pretty good efficacy. So we're at least seeing, instead of that yin and yang, you're actually having a drug that's showing really good efficacy, blocking IL-17A and F. But this is not approved yet, but it's been interesting to follow some of the data at the national meetings that this could change the way that we might be answering that question. Deucravacitinib is a TYK2 inhibitor. It's out for psoriatic arthritis, not yet out for psoriatic arthritis, but some early data showing some good efficacy against the joints. You can see here ACR 20 as high as 62%, ACR 50 at 32%, and ACR 70 at 19% for psoriatic arthritis. So these are some of the early data. Lianne sort of went over this. We do have a portion of psoriatic arthritis patients that have axial involvement, so maybe about 10, 15, 20% of patients that you see will present with more classic inflammatory back symptoms. And the question is, in that group, would you think a little differently about drug treatment? And we don't have a lot of studies on this, but I just wanted to look at the Maximize study, which did try to highlight this axial domain, looking at secukinumab versus placebo. And it did show really very good efficacy, both in many domains, but including the axial domain that I just wanted to highlight. So I think the point of this is just to remind us that it's not just a question of whether or not TNF should be the standard of care for psoriatic arthritis, but to really understand some of the subgroups and what's really bothering the patient. We also should probably remind ourselves that many people have other comorbidities. So if they have concomitant uveitis, or depression, then some of these drugs may not be what you want to use ever, just because of some of the black box warnings. So it's just something to keep in mind, as we all know. So I wanted to just sort of towards the end of my talk, just remind us that we're really all the way only at the left, really meaning that to your right, sorry, where we're seeing a patient and we are deciding a drug that they're using and showing good or bad outcomes. But in the psoriatic arthritis world, we're really lucky that we have sort of a precursor, right? Most people have psoriasis before they develop psoriatic arthritis. So there's been a lot of studies really taking us back to the very beginning and trying to better understand what really triggers that transition, or is it that we're not good enough to pick up, subclinical disease, or there's a preclinical versus like an activated form. And I just think that's really important as we're thinking about the patient that's coming to us. They may be coming at different levels, and we may be able to do future treatment interventions that are much more sophisticated than what we're doing now, which is really trial and error. So I just wanted to remind us the spectrum of how people present. And lastly, because this is something that I'm really interested in, is to really highlight that in addition to all the great drug treatments that I just went over, there's also a huge role of looking at health and wellness strategies for our patients, meaning that many times they have better relationships with us as a rheumatologist than their primary care, right? Because they're seeing us for their care. And I think it's important that we take some time to remind them, if they don't have very healthy lifestyle habits, that we can really make a difference by encouraging exercise, nutrition, sleep, mindfulness, and social connectedness for our patients that are dealing with chronic diseases. So in that realm, I won't have a lot of time to talk about immune strength, but just wanted to mention this is one of many different programs that we're highlighting. We're doing this trial at the Cleveland Clinic. This has been a grant that I received through the National Psoriasis Foundation called Immune Strength that Len Calabrese and I are piloting. It's a 10-week online program where we're offering to patients, in addition to all the treatments that they're getting by their rheumatologist, to help them actually create some better lifestyle habits. We know that we're having less and less time in the clinic, yet these questions are still very important, and this is just one of many different ways that we can hopefully connect with our patients to help them improve their health outcomes. So I think that is my last slide, and just my summary, which is just going over, hopefully I've convinced you the wide spectrum of psoriatic arthritis, how they present, and their poor quality of life burden, and hopefully been able to get you excited about all the different medicines that are now available and still coming pretty fast, and hopefully highlighting the different manifestations, comorbidities, and severity of skin versus joints will help you think about individualized treatment plans for our patients. So thanks.